always a great destination for a meeting. My name's Mark Sinclair. I'm Vice President of the Society, and it's my pleasure to be the chair for this session and to be able to introduce our two excellent speakers. Firstly, of course, you'll have Dr. Andrew Miller, our President. He'll be delivering the Geoffrey K. Oration, which is traditionally one of the last and very important duties of the President as he or she finishes their time of service. Now, Andrew is, of course, a specialist anaesthetist in WA, and somehow, despite all his duties, he manages to find time to spend most of his time in direct patient care. Andrew also has a legal education, which has led to his involvement in a range of organisations involved in the governance and strategy, particularly of not-for-profit organisations. Andrew, of course, has served time on the AMA, as I'm sure you're aware, was WA AMA chair prior to being our president, and for his services to the AMA, he's also on the roll of fellows of the AMA, which is a very high honour to be given by the AMA. Andrew's also a graduate and a fellow of the Australian Institute of Company Directors, and is on the executive of AusSage, which is a multidisciplinary group dedicated to the well-being of Australians before, during and after the COVID pandemic. And also is a reviewer for medical journals in his spare time. So without any further from me, I'd like you please to welcome our President to give the Geoffrey K. Oration, Dr. Andrew Miller.
Thank you very much, Mark, and look forward to hearing more from you later on this afternoon. Now, we don't have Glaucom Flecken, nor do we have Fauci here this afternoon. So I'll try and range between those two in order to give you a bit of a flavour of their strong presence in Darwin next year. So the Geoffrey K. Oration is a great honour, and it doesn't help when all of the ex-presidents come up to you in the last 24 hours before giving the Geoffrey K. Oration to say, please don't stuff it up. But I did want to talk a little bit about all the mistakes I have made and keep it as a fairly brief address. I want to tell you some things before I'm done as President. This is really passing on of a baton that was never mine to keep, but it was my honour and privilege to carry for a while. I've got a lot to say, and I've tried to choose my words carefully, and I want to tell you all about a profession that I love, that I'm so grateful for, and that I find I'm coming to peace with after struggling for nearly 30 years with being at first too ignorant, then too clever, then too regional for a while, then too general, then too paediatric, then too adult, then too public, then too private, depending on which day of the week that it was. I'll tell you the essence of the talk at the start, and then if you find my voice monotonal, irritating or soporific, you're welcome to leave, because this is really the point of what I'm going to then expand on over the next little while. The ratio decidendi, which in the law, the Latin, is the chain of reasoning, the basis on which a decision of a case is made, and that the most honourable judges usually try to hide somewhere deep in their judgment so that law students have to spend hours poring over it and trying to figure out what were they really trying to say. Being scientists and anaesthetists, and we get to the point, we don't have time to muck around, I thought I'd just put it up the front here. The leadership role of anaesthetists is driven within medicine and the community by the discipline that is invoked on us by the proximate measurement of our performance. Another way of putting that is that we are still there while the body is warm. Our patient disasters happen before our eyes, and we have to intervene, sometimes directly, to prevent them from happening. That's what we're here training for. That's what we've been doing ALS courses for. And that's quite different to a lot of branches of healthcare, where really it is about the chronic modulation of things. We are always in the presence of our patients. The second point that I want to make is that we are doctors, and that has implications. We take that kind of for granted, that we put it on as our salutation when we fill out a form. It's probably on your airline bookings. but it also comes with the responsibilities that are not always obvious to those of us who spend our entire lives, or most of them, inside operating theatres. And I would argue that we must embrace that responsibility and not limit our doctoring to the simple practice of anaesthesia, the relatively simple practice of anaesthesia, but to expand it to consider the entire patient and the entire environment within which we treat that patient, because the performance of anaesthesia is part of a treatment. And then thirdly, this is my challenge to you and to the ASA and to the college and to the AMA and to everyone else involved in our profession. I don't think we're doing well enough. I think we're a bit on the back foot. I think there are others who are ascendant in the health space who are pushing their barrow when our profession has enormous amounts to offer, and sometimes I worry we sit on our laurels a bit. I think we must become much more sophisticated in a drive for excellence in our political, bureaucratic and public advocacy for our profession and for our patients. Understanding things is a matter of scale, focus and orientation. This is one view of life, one of many windows through which you can see things, and you can perhaps, the anaesthetists here are obviously interested to know how my day got so bad that I was taking this picture. For those of you who don't spend a lot of your time looking into the sublaryngeal space, the vocal cords are just a little bit to the foreground to be in this picture. This is below the vocal cords. That's someone's trachea in the distance, and that's a needle. How can we make sense of life from down here in a trachea that inexplicably has this thing sticking into it, but no airway? Where's the airway gone? Can you see and hear the political landscape of the future of anaesthesia in Australia and the world? How do we make sense of it? Is what we read in the papers or the journals or on social media helping us? Will it help us in this situation? As we try to find understanding of what it is to be a doctor and who our patients are in the world in which they operate, we should start with where we've come from. And where have we come from? Well, we've come from Geoffrey Kay. And Geoffrey Kay went to a pub in Hobart in 1934 to meet a few other blokes, and this happened 89 years ago. And this is a photo of the plaque that's now unveiled again in that pub, and it lists the founding members at the first meeting of the Australian Society of Anaesthetists in January 1934 at Hadley's Hotel. It's probably quite nice weather in Hobart then. And there were some big names of anaesthesia there. There was Dr. Lillies from Victoria, Gilbert Brown from South Australia, Gilbert Troop from WA. Gilbert had been a popular name around the turn of the century. We've got Harry Dillon from New South Wales, Ivor Houghton from New South Wales, and then Geoffrey Kay from Victoria there at the first meeting. And this is him sitting there at the meeting waiting for the others to arrive. Someone obviously had their iPhone there and recognised who it was, and they took a quick snap. And I like to believe the story that was told to me that the original photo from which this portrait was painted, or at least and perhaps even the original painting itself, there was a cigarette in the right hand between the index and the middle finger, with a bit of smoke wafting up past his head. And I've asked senior members of the society whether they think that that might have been true, and they're pretty generally agreed that it probably was at the time. So there might be a little bit of revisionist portraiture going on at the ASA. Where else have we come from? This is Dr. Andrew Olney and Dr. Hilton Swan. And they're two friends and anaesthetists that I loved and that we all lost. They were my age and we went through training around the same time, and they both died in their prime from cancer. And the reason that I wanted to talk about them today was not just to remember them and all the others that you've lost that I don't know, but I know you love them just as much as I love these two clowns. The reason I wanted to talk about them is that they had peculiar personalities. And when you start poking around in anaesthesia, it's actually not that hard to find a few peculiar personalities. And neither of these two were anything other than wildly popular with their patients. Their patients thought they were fantastic. Both of them would get in trouble at work for not necessarily following the proper protocols and decorum with people, with the rules all of the time. But neither of them could deal with conflict without great distress. They never engaged in conflict as part of their profession. They were really quite fragile. And because of their training to do what they did, which is to try and instantly form a goodwill rapport with people, to have someone trust you with something incredibly intimate. One of the most intimate things you can possibly do with someone is to put your phone on silent. I'm sorry, I misread. One of the most intimate things you can do for someone is to make them unconscious. They don't know if you're going to be able to bring them back again. You have to develop that trust in an instant, and the skill that you develop in gaining that trust from people, the people who are very, very good at it, and these two were two of the best I've ever known, those people then find it difficult to operate in the rest of the world without that same degree of engagement. So when there's conflict, they're really quite vulnerable and quite open to the feelings that result, unlike a lawyer, unlike a builder, unlike a car dealer. We, peculiar anaesthetists, become disabled. We are obsessive about particular things, and we're going to talk about the reason why that is and perhaps give some of an explanation to the distressed spouses and families of all anaesthetists. So we shouldn't get exasperated around us when the world becomes frustrating. We should try and understand it better. The first thing I said was that the leadership role of anaesthetists is driven by discipline invoked by the proximate measurement of our performance. We're constantly being measured for our performance, a bit like stand-up comedians who know instantly. They don't need reviews. There's no laughs as they walk out of the room, they already know. The anaesthetist is the same. We have our neck on the line every day, and there are people there observing what we do, as they should be. But that puts in a background level of stress into everything we do. Now, in defending or explaining or apologising for the mistakes that I have made, it is necessary to refer to a philosophy. None of us can proceed without philosophy. Bertrand Russell, I think, is a philosopher that I can understand. And I think that it resonates with me that the good life is one inspired by love and guided by knowledge. My trip through anaesthesia, I like to think, has been a good life inspired by love and guided by knowledge. I'm yet to find anything better than the 1,000-year philosophy that Bertrand Russell was famous for when he was challenged to give a philosophy that could be just as applicable in 1,000 years' time as it is now, not something modern for the times. And he said the first limb is to deal with the facts as they are, not as we wish them to be, and that will save you a lot of wasted time. And that is what we teach our trainees every single day. If there's no CO2, but the heart is beating, your airway is probably not in the trachea. You have to deal with the facts as they are, not as you wish them to be. You may be certain you saw that tube go through the cords. We don't care. That's not the facts as they are. And we can save ourselves a lot of time. If there are no women in leadership positions within your profession, there is something wrong with the selection process for your leadership. Either you're putting them all off or you're not selecting the right ones, but you have to have a look at that process. We can argue all day about merit and whatever else you want to talk about, but the facts are that that's not the way it should be if we have approximate gender equality within our specialty, which we will before too long. The second limb of Russell's philosophy was that when dealing with ethical issues, when dealing with what is the right thing to do, should we commit genocide in order to make more space for our particular race? His answer to that was, do the good thing and not the bad thing. So that's it. Deal with the facts as they are and do the good thing, not the bad thing. And if we practice that way as anaesthetists, I figure that's as good as any other operational philosophy. So when faced with an ethical choice, if we're finding it hard to figure out what the good thing is to do, in my experience, that's most often because you know what the good thing is, but you'd kind of rather do the bad thing, and you're just trying to buy a bit of time to find your way around the side. So when I'm the head of the department and my junior doctors are submitting overtime claims, and on the other side, the person who's a pain in the neck who runs the budget for the department is saying to me, you're out of money and you have to sort this out and there'll be no more overtime claims, I know what the good thing is, and it's only a difficult situation for me to decide what to do because, you know, it's a bit awkward to do the right thing. If you're never having conflict, if you never alienate anyone, all that tells you is that you are getting on quite well with some people who have personality disorders and who are doing the wrong thing. And they're not in short supply within hospitals. Sadly, they get attracted to positions of leadership, particularly in areas where no one else wants to be in positions of leadership. So we unfortunately have to occasionally wade into conflict. Should I support equity, inclusion and diversity in medicine by listening to other people's experiences with an open mind? Should I support an Indigenous voice to Parliament when all the health organisations that work in Indigenous health say it's going to be a positive move worth trying? Should I support queer or disabled rights rather than accept discrimination continuing? Perhaps we can get some guidance from the Declaration of Geneva with a modern version of the Hippocratic Oath that all the public seem to think that we swear and none of us do. But the Declaration of Geneva, many of us have taken as a pledge at one stage. And I will take the moment to read it and say that I solemnly pledge to dedicate my life to the service of humanity. The health and well-being of my patient will be my first consideration. Doesn't matter who my patient is. I will respect the autonomy and dignity of my patient. I will maintain the utmost respect for human life. I will not permit considerations of age, disease or disability. Age, disease or disability. We had 35 deaths from COVID, but it's okay, they were all old. Age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing or any other factor to intervene between my duty and my patient. I will respect the secrets confided in me even after the patient has died. I will practice my profession with conscience and dignity and in accordance with good medical practice. I will foster the honour and noble traditions of the medical profession. I will give to my teachers, colleagues and students the respect and gratitude that is their due. I will share my medical knowledge for the benefit of the patient advancement of healthcare. I will attend to my own health, well-being and abilities in order to provide care of the highest standards. I will not use my medical knowledge to violate human rights and civil liberties, even under threat, and I make these promises solemnly, freely and upon my honour. Maybe we should do that instead of the surgical checklist at the start of the case. Certainly it might wake them up. We could get some revenge for them starting to include the fire risk in all of my endoscopy cases where there's no diathermy. You get a little jaded when you're getting close to your 60th birthday, but it's important to, I guess, harness that jadedness and turn it in the right direction. We've copped some blowback as an organisation for even introducing some discussion around the referendum coming up, saying we should stay out of this sort of thing. But health organisations across the country have pledged their support for the voice. We didn't pledge our support for the voice. We asked people to consider it, and we backed the line of both Albanese and Dutton in saying that there should be some sort of voice to the Parliament. Whether it's this one or another one, of course, will be up to the voters. But can we say that we're not going to be involved in these sort of things? Yet we're going to be a serious medical organisation when the AMA, the ANMF, the Cancer Council, the Heart Foundation, the Eye Research Australia, Diabetes Victoria, ANSCA and most of the other colleges and so on, over 100 of other health organisations have all taken a very solid stand on this issue when we just said we would like our members to consider it. If we want to be serious influencers in health policy, we cannot choose to only call up the government and make a meeting with the minister and get off the fence when the issue affects our remuneration. They see through that. People know who you are if all you ever do is turn up and say we want to talk to you about getting something included on the schedule. The new generation of anaesthetists also wants to know if we're going to stand up for issues, and if not, why not? And we may not agree on it all, but no one agrees on everything all the time, even on our clinical issues. This is another anaesthetist that I lost and then found again years after he died. He was alive in this picture on the wall at the Australian War Museum. This is my father, Ian Miller. He was in this photo in 1970, a Lieutenant Colonel in Vung Tau, the Australian 1st Field Hospital in Vietnam. I know it's him because his tongue is sticking out the front of his mouth because he's concentrating. And all of you anaesthetists know what he's trying to figure out at the moment. I also know it's him because his name's written on his pocket. So you'll be looking here at the airway, the breathing, the circulation. You can see they've got some fluids up on the bar there. They've got some pressure bags ready to go because it's a dust-off trauma area where the helicopters drop them off, drag some teenage kid out of the jungle somewhere and bring them back into the dust-off area. And as anaesthetists, that's what we do. We're looking down. We're looking at that scene. We're trying to figure out, can we save this kid? And because he's a kid, you probably can. But that's not all the doctors should be looking at. Remember my third point. To really have influence over our professional environment and our conditions and our patient outcomes, we must become much more sophisticated in a drive for excellence in our political, bureaucratic and public advocacy for our profession and patients. When he's finished with this case, is it not relevant for this doctor to consider what he's doing there? Whose war was this? What was this teenager fighting for? Why should we be having to put him back together? Should he stay out of that and just do the resus, just do as he's told? Well, not if we're going to fulfil the Geneva Convention. Not unless we step back from the practice of medicine and just restrict ourselves to being technicians for hire, surrender the doctor part of the title and just be an anaesthetist. I think doctors would do well to follow Desmond Tutu's advice. He said that if you spend a lot of your time fishing bodies out of the river, you should probably take a day off and go upstream and see who's pushing them in. Maybe he's going to speak in Darwin, that'd be good. You saw this plaque before at the start of the ASA, and then along came this goose to crash the party. I actually look dorky enough in this photo to be an anaesthetist. I'm only really half an anaesthetist. It's been my privilege and my disability and my kind of addiction. All anaesthetists have an addiction, you just have to make it the right one. Mine has been to have an unusual education. So I also have a law degree, partly in order to just annoy lawyers. Like Mark Sus, our treasurer, comes in very handy, expands part of your thinking that you didn't know about. Of course, I have my college diploma. I'm also a fellow of the Australian College of Legal Medicine, and I got my fellowship at the Australian Institute of Company Directors because I like to know how things run. And I spent my time, I did my service on the federal AMA, 8 years at the table of federal AMA politics. Mukesh Haikaval, who many of you might know from this town, whenever we meet, he shakes my hand and he feels my back for the scars. He says, how are the scars coming on? From your time on the Federal Council of the AMA. That's a snake pit if ever there was one. And I spent 3 years as AMA president, and throughout the COVID pandemic was on the news quite a lot. And in the course of all of these things, I suffered, like everybody, the Dunning-Kruger effect. I just want to take you through this little roller coaster. So you see me in this photo here. Look at that clown. He looks like he knows everything. That's because he's in this first red circle here. That's high confidence against low competence. Starting out on any particular venture. I was very confident and I felt like I knew everything I needed to know about medical politics when I first got involved with the AMA. And then I came along to the ASA, and this is one of our council meetings. This is Guy Christie-Taylor at the end there. Guy Christie-Taylor was one of the top 10 ASA presidents. That was a joke. He was a very good president. One of the top 10 I've ever seen. Sorry, I'll tell you if it's a joke when you don't laugh because you're not getting the cue. I do have a monotonal voice. When I joined the ASA board more than 10 years ago, there was only one woman who'd been involved, the talented Dr. Feeney, and occasionally Dr. Vita Vilunas from Canberra. And us men around the table, we didn't know what we didn't know. We were high on in terms of equity and inclusion, we were high on the confidence and low on the competence side of things. There was nothing wrong with most of the men, as far as I could tell. Got to know some of them reasonably well. I'm a bit cautious these days. You sometimes can't spot a bullying predator very easily as a man. We're a bit blinded to that. So it pays to be cautious in making blanket endorsements of males, and even females at times. I've been caught out before, particularly though by charming male predator doctors. You know, one doctor who I got on very well with, and we even had dinner together several times. And I found out subsequently that he'd sexually assaulted two of my classmates in medicine. And I fully believed them. I have no reason to not believe them. But that is a phenomenon that can occur. But we didn't know what we didn't know. And we cannot properly understand and address the needs of half of our population unless they sit at the table and unless they occupy leadership positions. So in goodwill, we set out and tried hard to change it. And we got to this bit on the curve where we thought, oh, there's more to this than we thought. And that applied to a lot of issues, whether it's the MBS review, whether it's clinical things. Often I'm very good at wading into something, opening my mouth about something, and that is a great way to get taught by the actual experts in the field. Particularly on something like social media, where I go on Twitter and make a comment, and within 10 minutes you have someone who actually knows what they're talking reply to you and say, hey, you might want to just, you know, be quiet and learn something here. And if you do it enough times, it's a bit like studying for a first part or a second part. After a while, there's not that many questions that you haven't seen before. I can't emphasise enough the importance of being mentally flexible and of pausing before expressing an opinion and of accepting that maybe you're not right about something you're sure about. We have to understand that when you live in a jungle, like we do, change is inevitable, that what you used to do will not be good enough in the future. What you used to do will not be good enough in the future. What I do now will not be good enough in the future. When governments change health settings that affect us in all of our operating theatres and procedure rooms, we need to understand who's doing it, how they're doing it, what levers are available for us to influence such decisions before they are made. Now, we're very good at complaining in a tea room, a corridor, an operating theatre, an MAC meeting. We're even good at complaining on social media. We get together sometimes so that we can all complain at one another at a very nice conference and a dinner like this, and we can go to state and federal committee meetings of our ASA. All of that is of very little external utility. It may be great for psychotherapy, and it may give our family members some relief for a little while from listening to us, the family members that do still listen to us, but it doesn't change things. Even if we can work out who is making these decisions and why they are making these decisions, complaining to them doesn't even necessarily change things. We have to get a lot more sophisticated. And so we did. This is why it was very important that we had Dr. Susie New step up at the time. She was a watershed, and I pushed very hard for her to step up to the presidency when we were in need of leadership. Because I knew she was better than the rest of us in the way that propofol is better than thiopentone or chocolate cake is better than carrot cake. Or that her presidency represented a stepwise progression for the profession, because it was not just a gender mould she was demonstrating was kind of irrelevant, but the whole way of thinking that she's brought. I don't want people to get distracted by the fact that this was a good move for our gender equity, by the fact that she also brought skills and a way of thinking that we have really, really benefited from. She has, through her podcasts and her Women in Leadership initiatives and publications, captured and communicated more in a couple of years than we thought possible. She's a living demonstration of how feminism and diversity deliver better outcomes, not just for women, but for all of us. She's a good demonstration of how the patriarchy is not a problem just for women, but it's a problem for all of us. And she was very patient with me on Zoom meetings, because you might notice on the top right there, that's my daughter on a train during a board meeting where Susie was chairing the meeting and I was having to undertake public transport at the time. So I got a little bit depressed during the reign of Susie New because I thought, well, we're now in the phase of I may never understand this. This seems like a huge smorgasbord of issues. We've got MBS review. We now have COVID bearing down upon us. We're now having wars with infection control people because in many instances anaesthetists understood the airborne spread of disease much better than the hand washing brigade, whose solution to everything is let's have more hand washing modules and more hand cleaner everywhere. And we're saying patients are coughing on us and they were saying, no, that'll drop to the ground within 1.5 metres, and we're just shaking our heads. So where are we now? Well, we've got to go back to the data, the facts as they are, not as we wish them to be. We've got to keep doing the good things, or the hard-fought gains of our specialty over the last 40 and the last 100 years might be surrendered, and that shouldn't happen. So we'll need to be equitable, inclusive, diverse, and we will need to be doctors who care about patients. This is my thesis. Anything less than that will compromise the profession, and that will end up compromising the airway, the blood pressure, the kindness, the pain control, and the humanity. So what is the thing the love that inspires each of us? Bertrand Russell said the good life is the one inspired by love and guided by knowledge. Now, these are my 3 kids who are objectively better than everyone else's kids. And I would do anything for them. It is a fallacy to try to separate our life and our world outside of anaesthesia from our life and our world inside of anaesthesia. And when we attempt to keep this artificial distinction between our professional and personal lives going, then harm can come from it. If I'm not coping in my family life, I cannot work well. In promoting well-being and support for practitioners, if that all sounds a bit touchy-feely, we're just acknowledging the facts as they are, which is that you can enforce all of the hand hygiene you like, but someone in the middle of a family crisis is distractible in the operating theatre. Someone who is depressed, who is not being treated, is at risk of addiction. The data does not lie. If your recycling bin is full of red wine bottles by the middle of the week, the data is telling us that there is an important issue. The idea that this world, the one you see on the screen there, where this is me getting married to Shannon 8 days ago, you can give her your commiserations afterwards. If you think that that world there can possibly be separate from this world, then that's clearly a fantasy and a construct that we must reject as being untrue. When we allow the outside world to be recognised as important in the theatre world, you're seeing it. We will get better outcomes because we can start to deal with the effects they have on each other. Anaesthetists are very, very good in navigating at this place, and anaesthetists are very, very triggered by pulse oximetry. You can see why I stopped to take that photo. It's cold in here. It's only 19 degrees and 50% humidity because every hospital air conditioning system is an untamable beast. And it's run by an evil spirit. And so I wear a Maoist jacket over my Maoist scrubs, and there's a warm air machine blowing on the patient that I use on the buddy system occasionally up my trouser leg, because all of our thermoregulation, along with much of our homeostasis, has been impaired by the onset of general anaesthesia. If you zoom in a bit further to this person who's laying on an operating tables haven't changed since the etherdome, really. I mean, they might have got a bit electric, but they're still pretty much just a flat table, which is why it's not comfortable. I tell every single patient who complains about it. But the keen-eyed, also, the ones who spotted the oximetry, see it's a lot better in this room, so you can all calm down. You will notice something fantastic about this operation, which is that everyone else has gone and left the anaesthetist in peace. It's just a bit of an illusion for the camera. There is an anaesthetic assistant hiding over in the corner somewhere, updating their profile. But it is a fairly pleasant time when the surgeon gets lost. The patient looks to be asleep, but they are not asleep. Let's never forget that. They're suspended from life, and even the timekeeping clock in their reticular activating system has stopped. The next bit is not filmed for obvious reasons. I only have one photo of what happened after the surgeon came back from their break of having been spending quite some time away. But I will describe to you what happened. There's a surgeon peering down a microscope into a metal tube that is in the person's mouth, and in their right hand they are holding aloft a device which appears to be an endotracheal tube connected to some hoses, and there is some blood dripping off the end of the endotracheal tube, and the surgeon is saying, "I can't get it back in." This is not what was expected to happen. It is a wrong moment. And in the anaesthetist's mind, the hypoxia clock has started. And the anaesthetist is doing that thing they really do not like to do. They're standing up. At the other end of the hose, there's a machine. It's a very expensive one, and we'll come back to that. And near that is the anaesthetist. The next slide is slightly clinically graphic. So if you're a civilian and you don't like to see blood, then avert your eyes. This is what the surgeon showed me. They had been lasering the larynx, and that's kind of what's left of it. And the dark area at the top right here, that is the trachea. And I said, "Well, you're an ENT surgeon. I imagine you're fairly handy with establishing all kinds of airways, and I figure you've created this problem. It's only fair that you should sort it out, you idiot." To his credit, apart from having tiny hands and a relatively cooperative manner, he's pretty slick with tracheostomies. I wouldn't agree to work with him on a case like this if he wasn't. And he said, "She really doesn't want to trachea this patient. She's got advanced cancer here, and she has said she doesn't want to die with a trachea in." And I said, "Well, she's not going to die with a trachea in then if you don't do anything." And he said, but you've never failed to intubate anybody before." And I said, "You've just not been paying attention." So, as a specialty, we decided long ago that patients should not die from preventable causes on our watch. All of the patients, not just some of them, physicians, all of our patients, we try and gather up and keep going. We don't reduce the acuity of our response because someone has only a few weeks to live. We still practice at the extent of our capabilities. We stop short of providing futile care, but having started an anaesthetic, we finish it in the recovery room or the ICU. We don't finish it in the operating theatre, except in the most extreme circumstances, and usually when that was a fairly good risk going into it. Doing this is our only operational, ethical and morally defensible path. When we're still giving chemo to those people who we know are going to die, and fairly soon, we should not be relaxing anaesthesia rigour, nor should we be infecting them with nosocomial diseases in our hospitals where we can prevent that. We should be wearing masks around our immunocompromised patients. In Australia, we have leaders like Runciman and New Zealand, Mary and others that drove us towards the science of risk analysis and measurement and control, and we went in the correct scientific direction, and we should lead other doctors the same way. The standards of our college are rightly applied across hospitals, and they don't provide us the equipment we want because they want to. They give it to us because they've been bullied into it, and they have to, and we must continue that pressure, and we must support the excellence of our college in driving that. I'm not going to bore you with the full details here, but it turned into, after that whole thing, things got worse. Because he did put a trachea in and it didn't work. There's not really anything on the algorithm to say what to do when your front of neck access doesn't work, and when the anaesthetic nurses started crying and left the room, and some senior looking person you've never seen before is wearing civilian clothes, a lopsided beret, and starts asking, "Have you tried to give oxygen?" and starts writing something on a clipboard in response to the Met call that's been put out from the theatre. You know you're deep in the jungle at that point. I put an MLT tube down almost blind from above, and I tried it enough times that eventually it went in, and we got some saturations up above the 50s, and the grumpy surgeon figured out that his trachea was in the mediastinum and the anatomy was all a bit distorted. And the patient lived another few weeks, and she spent wonderful and sad time with her family. But if we did not have a sophisticated approach, and if we weren't able to find our way through the jungle, would it have mattered? Well, the statistics say no, but we shouldn't trust the statistics. We should do the good thing. Her family would not agree that it would have been a bad thing if we hadn't been able, through the use of anaesthesia training, despite the best efforts of ENT surgeons, to help that patient. Part of the reason that anaesthetists are coded by predisposition often and training always towards obsessive adherence to particular routines which are obscure to everybody else is that we need to find a way through the jungle. The importance we attach to seemingly minor details can affect our personal life. By this I mean we can seem unfairly relaxed about many things, but then be completely inflexible in regard to certain key steps in a process which to someone unfamiliar with that particular anaesthetist might seem insignificant. Now this results in a confusing phenomenon whereby two anaesthetists performing anaesthesia for the same procedure, the same patient and surgeon will regard as essential in both sequence and composition completely different steps and techniques from one another. The paradox is that both of these anaesthetists are right. Their insistence on doing things their way is validated not only by their extraordinary success in terms of quality and safety, but one of the oldest aphorisms in medicine and anaesthesia and life being true: use the technique that works best for you. This is because the number of scenarios and variables is so great that we have to decide our own path to get from Westgate Park to Fitzroy Gardens, and it's safer over time if we stick to that path. Now, Google Maps will suggest that there's another route you can take, which is 13 minutes slower if you're going by car, and any cursory look at the map will tell you there's any number of ways of getting from that park to over there. But for each anaesthetist, we choose a path, and we prefer to stick to that path because otherwise we get distracted and we have to think too much and we end up getting lost. Here's another Google map for anaesthetists. I got a bit of a bruise on my soft little wrist. I did more CPR yesterday than I did doing a month of endoscopies when I was down at the ALS. Not more than 2 months. And these paths are very, very important, and they help us. And my argument is not only in the operating theatre. My argument is that we should be transporting this degree of pedantry, this degree of petty obsessive compulsion to the other things we do in life that is important to get right. So this is the point where we get to, I may never understand this. And many of you will recall spending hours in love with this diagram. I think I've learnt it, 3 or 4 times in my life. I did the American boards at one stage as well and had to learn it for that too. They're just obsessed with the Krebs cycle, the Americans. It's just the sort of thing that appeals to them, something they can test you on, and completely lacking in perspective. So while my patient was lying there with no airway whatsoever, it wasn't the Krebs cycle I was thinking about, and we have to refocus our perspective. It's easy to get down to a mitochondrial rabbit hole and right into that when dealing with a lack of oxygen. The ATP is frustrated, the nurses are upset, but then you have to zoom out a bit, and that will make you feel better. You look at things from the point of view that we're on a terrestrial planet. We have no idea what we're doing here, but we're orbiting a white dwarf star that's currently dominated at a macroscopic level by primates that have over-evolved frontal lobes and are running parliamentary systems. This is full credit to Banksy for this one, but many of those in leadership are part of the problem for the way that our system is set up. And that's part of what we need to address if we're going to be doctors, if we're going to treat all of our patients, and if we are going to be leaders within that system. Many of the people in political leadership demand a standard of honesty, frugality and integrity of doctors that is not enforced on the political class or the bureaucratic class. The performance of even our regulators, the many healthcare complaints bodies that we answer to, is not at the standard that we expect from an anaesthetist managing a cardiac arrest or a lost airway protocol, in my opinion. There don't seem to be consequences for failure of policy, like there would have been for the failure of that ENT surgeon who I would have totally thrown under the bus had there been a bad outcome in that theatre that day. Policymakers can decide, devise and defend after what seems often to be sham consultation, with an eye on managing stakeholders and the media cycle rather than health outcomes. These kind of double standards should not go unchallenged, but individual anaesthetists and doctors cannot challenge them, without great peril to their own career, their own mental health and their own whistleblowing life. The enthymeme, the unstated assumption of many in health bureaucracy, is that what are you going to do? Health is insoluble, it's just bumping along. If we give it all the money in the budget, it still wouldn't get any better, so, you know, this is the way it is. Anaesthetists don't accept that. We say we should be collecting data and figuring out ways of doing things better. That's what the ASA is here for. As we hit our 90 years next year, we're going to be honouring the past, celebrating the present. I think that means drinking champagne, although I think we should re-examine our relationship with alcohol, and embracing the future. Somewhere in the 150 million kilometres between the sun and the earth is our building in Chandos Street, and we have over 4,000 physician members. It's a healthy organisation financially and culturally for the most part, and we've got a good governance, strong new CEO, and we have got a humble but valuable piece of land in Sydney with a serviceable building and a much larger investment portfolio which has given us a lot of security. It exists to affect the things over which individual anaesthetists have little control: Medicare policy, private health insurance, public and private, the working conditions of the paediatric intensivists at Westmead Hospital in Sydney are all things about which we want to have an opinion on, but one individual can't carry that load. Our member funds are strong. In the time since I became involved in 2012, we've gone from net assets of 14.7 million to 34 million, but we've at the same time built the firepower of the organisation on a staff level. We're now in a position to add layers of staff to our policy and support areas and to grow our ambitions. We must at the same time increase the sophistication of what we expect from our doctor directors. They're all now doing extra study in order to contribute to our board: governance study, strategic study, and study around how to better relate to the world, how to network with people, the psychology of policy making and taking meetings. The phases of my involvement as Treasurer and Vice President and President over the last decade or so have been governance change, financial strength and increased sophistication through elevating the expectations of the capability and performance of the staff. In this year, these are the important bureaucrats and politicians that our organisation has met with using our consultants, and the reason workforce is stamped across the country is that that is the looming issue for every health service everywhere, which means that the ASA has to be front and centre in those discussions, because those discussions can be sensible or those discussions can go badly, as far as our craft group is concerned. But our increased firepower allows us to have that level of sophisticated advocacy and to build on it. Politicians and bureaucrats in particular, who have long memories and long careers, do not respect those who only seek to serve themselves. The AMA is frequently at odds with government and in fact gains more advantage for having the reputation of being prepared to take a stand. This helped us during the MBS review when we were arguing openly with Professors Brendan Murphy, not a big fan of our specialty in the public record, and Professor Bruce Robinson, also not a big fan of our specialty or colonoscopy or eye procedures. The Federal Health Minister swore at me on the phone during the COVID pandemic. He was actually blistering, completely blistering on the phone. We had a very, what you might call, robust conversation about the offloading of some German COVID positive patients into small private hospitals that were unprepared to deal with them. where we took a stand and said that the patient should go to the public system, which was prepared and stood ready with some of the same consultants, in fact, to look after them. After he spent some time swearing at me, he then called me back 45 minutes later and said, "How can we fix it?" I made some suggestions and he said, "Well, this is great, we're going to be able to do this and it's really good working with you." That's how it works in political circles. People are not offended if you take a stand. They want to know what your solutions are. We cannot afford to try not to ever upset anyone, or we might not get a tiny indexation on the MBS schedule. We also have the bandwidth to sponsor many other smart ideas, and this is something that we really need to increase, and I've been inspired about during this conference. We've been supporters of David Borshoff's anaesthetic crisis manual. He's not only an accomplished surfer, he's also sensibly been able to collate things that reading all of the different journals that apply to all of these different things just will not get us to. Listening to Professor Kaur at this conference, you start to understand the range of possibility of what anaesthesia can be involved in if we have the capacity to sponsor ideas and to sponsor people. So the more I've learnt, the more I realise, the less I know. And the more I realise that I don't find much out when I'm only stuck inside an operating theatre, and that I need my ASA and my college and my AMA and my interaction with the rest of the profession in order to succeed. Every anaesthetist in every location for every patient should be given the best chance they can of a good outcome. We should be powerful. We should be influential in the design of healthcare policy and systems. Anaesthetists should be notorious amongst policymakers that if you do not consult with us first, then you will get a metaphorical, probably blood nose. Probably metaphorical, I mean. When we are having a discussion about how the system should work, we need to consider who we are talking to, what is their position in the scheme, how does this discussion fit in with the strategy, and we should have our own versions of protocols and algorithms for dealing with the consequences. So here we come back to my roots, back to my dad, who, you know, I would reach out and touch him through the photo if I could. For those who came before, for those that we've lost, for those whose shoulders we stand on, for all doctors and their patients everywhere, for the people that we love and would die for, the leadership role of anaesthesia is because we're proximate to the measurement of our performance. We are doctors. We must embrace that responsibility and accept that it has higher responsibilities to be involved in things like social issues and not limit it. And we must become much more sophisticated in a drive for excellence in our political, bureaucratic and public advocacy for our profession and our patients. We should be humble, but we must fight hard and we must fight smart and we must never stop fighting. Thank you.